Hi, welcome to the episode 10 of Ask Giri the Physio Show. This episode we're going to talk about or discuss about neuro rehabilitation. What are the recent advances, right? It's neurological physiotherapy. So we've been providing the services in Edmonton for the last, I would say, 18 years. Instead, physiotherapy basically started as a neuro clinic from the physiotherapist working at Glenrose at that time. Then we took over from 2007 and we expanded the clinic to suit the neuro needs as well, with bigger gym, more parallel bars, low mat and everything. So that's the way it's going on right now. We are providing state-of-the-art neuro rehabilitation services in Edmonton. So this topic is close to my heart, and I'm always getting updated with conferences and all the innovations out there in the world and bring it to Edmonton so that the community, the neuro rehabilitation community in Edmonton gets benefit out of that. So that's the topic today, recent advances in neuro rehabilitation. So what is neuro rehabilitation? Basically helping people to regain their functional independence after a neurological insult or an injury. It can be anything. The common conditions we usually treat at the private practice setting is stroke, multiple sclerosis, spinal cord injury, transverse myelitis, Parkinson's, cerebral palsy, and various developmental delays for pediatric cases as well. So we do adult and pediatrics, both neuro rehabilitation at the clinic, and we have a couple of physiotherapists who trained in neurosciences, master's degree, postgraduate diplomas in neurodevelopmental therapy and things like that. So basically to regain functional independence, that's what neuro rehab does. And what has been the traditional approach to neuro rehabilitation all over the world? Because I've done my courses from the East and also in North America, so we kind of know, and also what's the system, how the system works in North America, in England, and also in Asian countries. We kind of a global idea of how the neuro rehabilitation process is. The traditional approaches for neuro rehabilitation is to teach compensatory techniques for the patient, right? If you can't use your one muscle group in this area to take your hand to the mouth, and you compensate by hiking the shoulder and then rotating a little bit to go up there. So that's a small example of how to teach compensatory techniques. That's been the traditional approach. And also the another very important thing is to promote neurological recovery. Whatever the insult may be, and what other recovery we can regain from that insulted neuro units. That is another thing. So compensatory techniques, how? We always, I told you already, we train the compensation for the lost function, right? By means of using some adaptive equipment also, like crutches, walkers, wheelchairs, braces. Braces has so many different types, ankle foot orthosis, knee ankle foot orthosis, and so many things. We usually use that for foot drop and things like that. With the recent innovations in the last couple of decades in neuro rehabilitation, some of the items in there, especially the braces, is something we are prescribing less nowadays, because we're going to talk about that later in the presentation, that we have so much functional electrical stimulation devices in use right now. So the use of brace is very limited right now, because we'll talk about that later. So these are the ways we are compensating. And promoting neurological recovery. What are the steps we do as a neurological physiotherapist to promote neurological recovery? So neuromuscular facilitation, to facilitate the muscles which doesn't want to work because the higher command is not giving proper commands for the muscles to work, right? Electrical muscle stimulation has been there always in neuro rehab, from the primitive stages of putting the electrodes on the things to the advanced stages now, which we will talk about down the presentation here. Vibrations, stimulations, biofeedback, right? Whatever you do, the audio visual biofeedback for the movements you make or the muscle contraction you make. There is quite a bit of biofeedback devices out there. And PNF, proprioceptive neuromuscular facilitation. This is old techniques. We still use it in the clinics by different movement patterns, how to facilitate the movement and the muscle work. And neurodevelopmental therapy. It's developed by Bobath in England, and I've been personally trained in neurodevelopmental therapy for almost more than 1 year full-time school, and we use that for both pediatric and adult rehabilitation in the neuro field, and quite a bit actually. And also it's not only neuro field, and you can't separate neuro and ortho, so we use some of these techniques in the ortho rehabilitation as well. It works very well. So these are the traditional methods, or some of them we still use it quite a bit to promote neurological recovery. So how do we know that what we are doing is working? So before we just do objective measurements and reassessments and outcome measures to see, now we can even prove it by means of investigations. The main thing here is functional MRI, right? We can see and prove that whatever we are doing is working. The functional MRI can show you the cortical restructuring process happening in the brain when we do specific protocol or treatment protocol or rehabilitation techniques and strategies with the patient, right? That's called the neuroplasticity. We're going to talk a little bit about neuroplasticity in this one actually. Yeah, functional MRI is a great tool because brain is not just a solid ball which is floating in a liquid inside a kind of a solid cranium or vault, right? And it can change anatomically, it can change structure and function if you do the right things. That is where neuroplasticity coming in. Okay, and also this MRI, functional MRI studies, it's showing the brain is capable of reorganization. That is the whole thing the neuro rehabilitation is based on. If brain cannot reorganize, whatever we do will not be effective. So that is a very, very good capacity of the brain to reorganize itself structurally and functionally. And we can increase the activities in different areas of the brain even after neurological injury. And there is a lot of processing, axonal sprouting and new dendrite formation. There's so many neurophysiological basis why we retrain the brain and how we retrain the brain, right? These activity patterns can be improved with various rehabilitation therapies. There is so much advancement now, constraint induced movement therapy. Just, you kind of block the unaffected arm and then use only the affected arm so that how the brain signals are helping. And mirror therapy, there's so many different techniques are there now we use in the clinics for neuro rehabilitation as well. And also sometimes for amputee rehabilitation as well. And the last point is the key. Improvement with the neuro rehabilitation can happen even years after the injury. Sometimes we hear from the patients that some medical professionals told them that after 2 years you will not have any neurological recovery. I do not think so. Research is not supporting that. Plus, in our clinical experience in the last 22 years of neuro rehabilitation, we know that number of years after you get a stroke or brain injury does not matter. You can still create neuroplasticity and you can still create restructuring. You can still create functional changes which can give you functional independence. May not be that fast as in earlier stages, but you can show some improvement, measurable improvement in the case. So don't worry if you're 10 years after stroke, you still want to improve something, go consult your physiotherapist who has experience in neurological rehabilitation so that he can help you or she can help you with that. So what are the resultant changes we are seeing in a neuro rehab? So we have so many new technologies to promote new neuroplasticity. We're going to discuss some of them today. And new therapeutic techniques, I just mentioned a couple of things before this slide. And counseling patients educate the patient regarding that there is a room for chronic improvement, right? It's not like, you get a stroke and you're been to a 6 weeks program, then you go home with a couple of sheets of home exercises, you do that for a couple of months and then you forget about the home exercises and then you start kind of degrading and plateauing and then you kind of just stuck there, right? Most of the patients find us online. And so our neurologists in Edmonton are really good. They're more aware of neuro rehabilitation services available in the community. We do get a lot of referrals directly from neurologists from various hospitals and the clinics and physiatrists and the nurse practitioners as well. So people are aware of things. We are also trying to educate everybody in the neuro rehab community. What's out there? What are the new innovations? What are the better outcomes? And what are the therapeutic things patients can access in the community? Hospitals have great program. Clinics have great program. With patient doesn't have to be sitting at home wondering what to do. They can be helped in a better way. And also patients, they're going themselves into online and searching and finding out all those things and calling us to get some help as well. The exercise programs can be created for the long-term rehabilitation. It can be continuously reassessed and progressed and graded and fit to your individual needs and functional needs. That's how we create exercise program for the neurological patients. So, little bit about neuroplasticity. Neuroplasticity has some criteria you should understand so that you can encourage yourself that I can still make myself better by doing certain things. Some of the things we're going to talk about is here, use it or lose it. That comes very much important in neuro rehabilitation, right? If you do not drive specific brain functions, you're going to lose it, right? So how do you drive specific brain functions? By doing specific functional tasks, which is guided by your healthcare practitioners, a neurological physiotherapist, or your occupational therapist, or your speech therapist, or vocational therapist, or recreational therapist, the whole neuro team, right? Neuro team is patient in the middle. Then we have your family doctor, your neurologist, your physiatrist, your PT, your OT, your speech therapist, recreational therapist, vocational therapist, social worker, your caregiver, your family members. Everybody is involved in the team. I want you guys to understand, like, everybody is important in the team, and everybody works together for the patient goals, and the communication between the team members is very important. That takes a lot of time and commitment for that, but we have to make that commitment so that everybody is informed what's going on with the patient, right? Use it and improve it, right? That's just, it's just common sense. If you do more, you're going to improve that function. Specificity, right? So it has to be very specific, the therapy you choose for your goal or the task you want to achieve. That's why most of the times in neuro sessions, we have session goals, right? We have long-term goals, short-term goals, and short-term goals will divide into session goals, and we achieve a specific session goal in the session. We don't go by the time, we just take as long as it takes for you to achieve that session goal. That's it. That's how we found it works in the clinical setup for us anyway. Repetition. Practice makes it perfect, doesn't it? You got to repeat and repeat. It says that, if you do 1,000 movements, your neuron will blink once, and that's a saying in the neuro field. So repetition does matter quite a bit. Intensity, how intense you are doing that work, right? It requires appropriate amount of intensity for the work you do. That matters too. And time matters, right? Different types of plasticity takes place in different times during the therapy. And especially when you're in the functional education, the mat, and the things you do in rolling, things you do in on all fours and kneeling, everything, it just what time you're doing, and it matters. And salience matters too. Salience, what is it important to that individual? What is their goal? What they want to achieve? It's a client-centered, patient-centered rehabilitation. That's where we are coming to. And we're going to focus on that. And as a physiotherapist and as a team, we are coaching them. And that is very important. The motivational interviewing, the biopsychosocial model we incorporate in the treatment of the patients. It can be any patient, it doesn't have to be a neuro patients, and that's more important. Age matters. Yeah, when you're young, your brain is young, you do get better a little bit faster than the older brain, but that doesn't mean the older brain does not retrain itself. Transference, that's another good ability there. The change in results that affects from one therapy, it affects the other therapy too. So for example, patient standing, and patient is standing with the butt sticking out, the hip extensors, the glutes, and the pattern is not firing very well. What do? I can't train them in standing for that. So I take them to the mat, we work on the rolling, right? Rolling from on his tummy to going to the back. The first activation in the lower limb is your hip extension, your glutes. So we work on the mat, and we try to facilitate that hip extension firing on the mat, and then we'll integrate that at a higher level, which is in standing. So that is why in the neuro rehabilitation, we work one session on the mat, one session on the parallel bar. So that's how we kind of break into small components, and we transfer the skills, what the patient learned in the mat, to the standing. And that goes, there's a small example that goes for different conditions as well. Interference, right? If you're stuck in one place, it can affect in the other place too. So when the patient has a bad experience with one technique or one strategy or one protocol, they might have that block in the neuroplasticity conversion. So we might have to make sure we counsel the patients, we educate them that if you failed in this, that's okay. We can try something else. Right? It's always a trial and error sometimes. There's nothing written on stone. There is so many tools we have in our box for the neuro rehabilitation. If one thing doesn't work, it's okay. It's absolutely fine. We can try something else. So, sorry, that went really fast. So those are the things we need to know about the neuroplasticity. So use it or lose it, use it and improve it. That's very important things. And the repetition matters, time matters, intensity matters, salience matters, age matters, and interference and transference. And these are the main things we roll around when it comes to neuroplasticity and devising the treatment plan for you when you have a neurological insult. So what are the new techniques? What are the new advances out there to promote neuroplasticity? Therapeutic robotics. Quite a bit of that is in place right now. and it's upcoming field. A lot of people, a lot of research, a lot of biomechanical research is going into that one. Functional electrical stimulation, it's a little more affordable and applicable in the private practice setup, and we talk about that as well. So therapeutic, the robotics here, they work by repetitive motion training, right? There's totally so many different types of robots for the upper limb, for the lower limb, for the trunk, for the whole body and everything. You're going to see some of those. We're not going to spend too much time on that. Oh, there you go. So here you see all the different types of robotics you can use for upper extremity. There are a lot of different names you can see, from MITs to Palo Alto universities to Rupert. What you see on the top, you're seeing that robotic upper extremity rehabilitative therapy, the gentleman using the hands like this with the lady in the back. That is the Rupert one. That's mainly for the upper limb functions. The other one you're seeing down there, it's MIT Manus upper limb active assisted exercises. We also had a University of Alberta research product with us called Rejoice. We worked with Rejoice. It's very similar to the picture you're seeing down there, and we worked with that for some patients. We don't do that anymore in the clinic anymore, but we did have that, and it was helpful. You manipulate that arm, and using the video game, you achieve objective results with it. These are some of the examples for upper extremity, and for the lower extremity, and we have Locomate system, which is on your right hand side. I'm sure the Glenrose Rehabilitation Hospital has Locomate system, and also the left side you have this auto ambulator. These are the lower extremity therapeutic robotics, and you also need a lot of space and things, and also it's very expensive equipment for the private practice. So we don't have it in the clinic, but these are things available out there. And functional electrical stimulation. So using electricity, different waveforms, different current patterns, and introduce them to the paralyzed muscles to mimic the functional patterns or the lost patterns of those patient, and stimulate the muscles. We have few things to do the functional electrical stimulation. There is also functional electrical stimulation bikes, where you sit on the bike with the electrodes on different places in your legs, and you kind of mimic the cycling patterns, and the functional electrical stimulation will help you to contract some of the muscles in your legs. I think the Stedward Center in Edmonton do have FES bike. We do not have FES bike in our clinic, but we use other FES devices in our clinic. So Bioness. Bioness is a great tool. We use it for the last almost 10 years here in Edmonton, and we bought it to Edmonton, and Glenrose uses it as well. We use it here. There are a couple of devices we use here. One is called L300 Go. This is a new evolutionary model compared to the previous traditional L300 we used to have with the foot sensor. Now this product L300 Go does not have a foot sensor. So I'm going to show you here. This is how it looks. It's kind of goes around just below the knee. What it does is we put the electrodes in here, and these electrodes stimulate the peroneal nerve on the side of your leg, so that when you have foot drop due to the upper motor neuron lesion. That means foot drop from the brain injury or spinal cord injury. If you have a foot drop, inability to bring your foot up, this will stimulate the nerve on the side of your leg, which that nerve supplies the muscles that can bring your foot up when you walk. Right, that happens quite nicely actually. This is the L300 Go, and we assess and make sure the candidate is right person for this, and then we use this programmer to kind of collect the data and then input this data into the control unit in this one here, and then patient can walk much better, because a lot of the falls in those foot drop cases happens because your foot is tripping on something. Okay, it can happen in stroke and also multiple sclerosis. It is mostly fatigue based foot drop. Patient might have a good strength to start with, and then after they walk 1 block or 2 blocks, the foot gets really fatigued, then they'll start dragging the foot. We call this fatigue based foot drop, and it helps really well for that as well. And it prevents falls. That's the very important thing. How many people fall and get hurt, and then so much associated problems, you can prevent that. And also the gait pattern improves much better. The compensation will reduce. You don't hike your hip very much. You don't rotate and circumduct your hip to compensate for the hip flexor weakness too much, because the foot is helping you a little bit. You still have to do your neuro rehabilitation exercises and your facilitation exercises. This is not a magic bullet. It helps you with one specific movement which helps in your functional patterns, but you still have to do your strength and neuro rehabilitation and stability training and gait and balance training to get better. So, and if you also have some thigh weakness and the knee issues, and we also have the thigh piece which goes on top of the thigh and which stimulates your quadriceps, I can make this one stimulate your quadriceps or hamstrings for depends on what the patient needs to stimulate whichever group I want, and incorporate that into the gait program. In the slide picture, you can see the lady on the left with a green t-shirt wearing both thigh strap and thigh unit and also the leg unit. So some people which we need control on the feet and foot and the knee, we use that one. So thigh piece also. And also we have something called H200. H stands for hand. That is for any persons to retrain the hand functions, right? So we kind of put it in this hand like this, we go like that, we put it in, and there is panels here. We choose different panels for different stimulation, different patterns, and then we stimulate the hand muscles to kind of enhance the hand functions. We use a lot of training with it. It is, again, it's not a magic device. It helps you, but you need to do the retraining exercises with that. So you see here patients using the H200. You see in the slide we are doing some weight bearing with open hand, with the weight bearing towards arm, some quadruped positioning, and you can also see a gentleman kind of stacking up the cans using the cylindrical grip, and also other gentlemen working on the knee and finger extension exercises using the Bioness H200. So these FES devices, innovative devices, are available for you to use and to get retrained for your functional independence. The next new technology or innovation we bought into the city of Edmonton is spons. You can see that it's a short form for portable neuromodulation stimulator. You see the device there in the slide. It has a piece which goes on the neck, and you have a electrode which goes on the tongue. It gently stimulates the tongue. Tongue is supplied by a couple of cranial nerves. Then we are stimulating the brainstem area and then causing some neuroplasticity changes, enhances the function, especially for gait and balance functions here. And FDA approved, and also in Canada, it's Health Canada approved for using in mild to moderate traumatic brain injury patients and also with multiple sclerosis patients. So we're getting a lot of calls and a lot of inquiries about this. We're getting patients started on programs, and it's a 14-week program, and it needs time commitment, and also it combines the in-clinic and also in-home exercises. The first week you come in for an assessment. It takes about a couple of hours to do a comprehensive assessment on that. We have to do a whole bunch of measurements and outcome measures and everything, and then you actually have to buy the equipment first. It's about 4,900 Canadian. You need to buy the equipment, and then the first week you come to the clinic almost every day, and then the second week you come to the clinic 3 times a week, and the next 12 weeks you take the machine and go home and do a structured home exercise program. In those times you can come to the clinic once or twice. So that is how it's been structured. It's a 14-week program. It's a University of Wisconsin project, and they had 75% of the people who used spons device for the gait and balance rehabilitation has shown positive therapeutic outcomes. And we are very excited to bring that to Edmonton and start using it for the neuro rehabilitation purposes for the patients here. And exoskeletons. This is again very expensive and product which is kind of has motors to stimulate your muscles and make you move. And there are so many different companies are producing different exoskeleton models. There's a couple of them here just to show what is up there for you to in the future. So what's the future direction goals? We want to regain the control of the body using only the thought waves. That's what we call brain-computer interface. So that is where we are heading towards with so much development in the technology. Just you think that you want to move your arm, and then that thought process can be captured by the electrode and goes to the computer. Then that will send the information to the electrodes in your arm, and then your arm will move, right? You're creating the movement just with your thought process. That's very advanced technology. A lot of companies are into it. Then we have 2 types of there. One is the brain-computer interface to functional electrical stimulation. That means you think about moving, and that thought pattern will stimulate the muscles through the electrodes, so you will execute a function. That's one form. The other form is brain-computer interface to exoskeleton braces. That means you think about it, that information is captured and sent to the motor which operates the brace, then it can move the brace so your body can move. So those are the two different areas in the direction of brain-computer interface. Okay, so that's where we stop the presentation here, and then I do have a couple of questions from the audiences, which Anu is going to ask me about it, then we'll explain about it.
Hey Giri, there are a couple of questions from the audience.
Okay.
So the very first question is Ted from Edmonton. He's asking that because of disability, cold weather and COVID situation, he's unable to have access to Neuro Rehab at the clinic.
Okay.
So he's asking what are the other options to seek treatment.
Great. Thanks Ted for the question. We do get this quite often. So the answers would be, number one is tele-rehabilitation. Tele-rehabilitation has become very popular during the COVID times. We do treat a lot of patients online, even neuro patients as well. And whatever the condition is, alone by yourself, or if you need somebody's help, your family members can involve in the neuro rehabilitation as well at home. So we will do everything online. As long as you have access to a good internet and any kind of devices. Another option, we send a neurophysiotherapist to your house to assess you and treat you at home, and that's another option. The third option is caregiver training, and caregiver can help you assist with exercises. Caregiver can come here and get trained with the physio and with you, and then you can continue the exercises with the caregiver at home. So those are the three options we have for the neuro patients to do to be active and to do the neuro rehabilitation from home. And do you have another question?
Yes, and there's one more question from Susan. She's also from Edmonton. She's asking that does any part of the PONS treatment protocol could be done as a tele-rehab?
Yes, the answer is yes. Susan, thanks for your question. As I said, PONS is a 14-week program. The first 2 weeks is a lot of clinic-based. The next 12 weeks is home-based. In that, you have to come to the clinic 2 times a week. So those 2 times per week visit to the clinic can be converted into tele-rehab sessions, as long as you do your home program properly. Definitely there's a room for that, tele-rehabilitation in PONS treatment. Okay, thank you so much, Anu. Anu is our physiotherapy assistant, and she's moving to Toronto end of this month. So this is the last episode Anu will be joining us. So thank you so much, Anu, for all the help. She's been with me for the last 10 episodes, helping me as a model and asking questions. Then we'll miss her very much. Thank you, Anu.
Thank you.
And then thanks a lot for the audience, and it's almost the end of the November now. If you like our episodes, please share and like and subscribe. We have a YouTube channel, we have a Facebook page, Ask Giri, the Physio Show, and also visit our website. If you haven't watched the previous episodes, or if you want to learn more about more things, you can visit our website, physioshow.ca. And if you have any questions, you can ask me directly through the email giri@physioshow.ca. Okay, have a great week, and I'll see you next month with new episodes. Bye.